I'm going to go ahead and get started. I'm Cynthia Snedden from the Clinical Research Support Team in the Cancer Center, and I'm chair of the Education Advisory Support Group. So Education Advisory Board, excuse me, we changed our name. So I was looking at an email. We're working between emails and online here. Okay, let me go ahead and introduce Dr. Davis, who's going to be bringing the lesson for us today. Dr. Davis is an associate professor in the Division of Medical Oncology and co-lead of the Gastrointestinal Oncology Program at the University of Colorado Cancer Center. She completed medical school at the University of Missouri-Columbia School of Medicine and completed her internships, residency, and fellowships at the University of Colorado School of Medicine. I'm sorry, but could everyone please mute their mics? I hear talking in the background. I just want people to be able to hear. Thank you. So Dr. Davis has a particular interest in improving treatment options for patients with hepatobiliary cancers and is involved in clinical and translational research efforts for these and other GI malignancies as an active member of the POEMS and GI oncology clinical trials teams. In her free time, Dr. Davis enjoys running, hiking, skiing, and traveling with her husband. So with that, I will let Dr. Davis take over, and we will be monitoring the chat during this talk. And if you have questions you'd like to enter there, you're welcome to. And then we'll try and save some time at the end for questions as well. So Dr. Davis, welcome, and thank you for being here.
Thank you so much. I really appreciate the opportunity to talk to you guys. Thanks for that kind introduction. And I see a lot of familiar names on the screen, so glad to be able to share with you guys today. And I'm just going to pull up my slides. Here we go. Okay. All right, you guys, are you able to see my screen and my slides?
Yes.
Okay, perfect. All right. And yes, this is all for you and your education. So please, at any time, if I'm saying something that doesn't make sense or you want me to go into more detail or a topic you want to pause for a minute, please just feel free to kind of chat message, and I'm happy to do that and expand upon anything or go in a different direction that's best for you guys. But yeah, I'm really excited today to share for you just some basic background information and kind of updates in the treatment of hepatobiliary cancers. As Cynthia said, this is my kind of key clinical interest within the GI space, and have been involved in various clinical trials in this area, as well as treating many patients with standard therapies in the clinic. So I think hepatobiliary cancers are kind of a less common group of cancers that you guys may be a little bit less familiar with. And so I'm going to kind of provide some background for each of these groups. And we really kind of divide them into hepatocellular carcinoma and biliary tract cancers. So we'll take some time to focus on each of those in terms of background, and then really spend the majority of time talking about treatment for these diseases. So let's start with hepatocellular carcinoma. So hepatocellular carcinoma, we refer to as HCC, and the risk factors for HCC are very specific. So in the United States, nearly all of the patients that I'm seeing in the oncology clinic with a diagnosis of HCC have underlying cirrhosis, so chronic scarring of the liver from a variety of causes. In our country, the most common causes are chronic infection with hepatitis C or alcohol, but also hepatitis B, and increasingly non-alcoholic fatty liver disease can be an underlying cause of cirrhosis as well. Less commonly, there are some inherited disorders like hemochromatosis that can cause this, but the majority of patients we're seeing are fitting in one of the first two categories there. This is important though, because if we look at it from the other side, so those patients who have cirrhosis, 1/3 of them will develop HCC in their lifetime. So the difficult part about the treatment of hepatocellular carcinoma is that we're not just dealing with one problem, we're dealing with two. These patients, by and large, have both a very severe life-threatening liver problem and cirrhosis in addition to having a cancer. There is a small subset of patients who have chronic hepatitis B infections that develop HCC without cirrhosis, but that's the kind of the exception to the rule. I want to point out kind of a unique aspect about the diagnosis of HCC. As you guys all know, the majority of the cancers that we see in the clinic, we require a tissue biopsy, right? We like to use the term tissue is the issue for making a cancer diagnosis. In this case, HCC, we don't actually require tissue. And the reason is that we really have very excellent imaging modalities that give a particular imaging appearance to help us make the diagnosis with supporting clinical factors that a biopsy is not required. And so I just wanted to show you this picture that walks through from left to right. In the left frame, you can see with the yellow arrow, this is what we call a triple phase CT. And this first phase in the first frame is a non-contrast CT of the liver. And you notice that only if we have that nice arrow sign as provided in this image, can we tell there's really an abnormality at all in the liver. It looks like a little bump on the surface, which actually cirrhosis can appear in that same way. But if we go to the next phase, which is the arterial phase, you'll notice the brightness of that lump, which distinguishes it as a likely hepatocellular carcinoma. And then diagnostic is that in the portal venous phase, which is that third image, that we see it wash out, meaning it does not stay bright. And the reason that we see that is because the liver is a unique organ that is supplied by portal venous and arterial circulation. But hepatocellular carcinoma gets its blood supply specifically from the arterial blood. So that's how we can distinguish between the two using these imaging modalities. You can also do a similar approach in diagnostic imaging through MRI with the same idea, but we really only consider this diagnostic in a person who has cirrhosis. Again, because the majority of our patients with HCC have that diagnosis, it's unusual to make the diagnosis without seeing that on imaging. And as such, if you were to meet a patient who has a presumed HCC by imaging criteria and no cirrhosis, we would still recommend a biopsy. A further support can be provided by alpha-fetoprotein levels, which are our tumor marker frequently used for HCC. And typically greater than 400 to 500, we kind of consider as enough support along with those imaging criteria to make the diagnosis with no biopsy required. That said, there are patients in which we do recommend the biopsy and kind of given an example already, but there are limitations. So the reason we don't universally do it and kind of use it for select populations when we have such a good imaging option is that these patients, because of the underlying cirrhosis, they have a higher risk of bleeding. So they have bleeding and clotting problems because of their liver disease. And as such, doing a biopsy is higher risk. If we're poking the liver, a very vascular organ, and these patients more likely to bleed, we're setting them up for higher risk of complications. There's also this conversation about seeding the biopsy track. And what that means is that when we go in to do a biopsy, and as we're bringing those cells out of the liver, again, a very vascular organ, there's this theoretical risk of kind of spreading the cells throughout the liver and the blood circulation, which could lead to metastatic disease or local recurrence or kind of worse local related symptoms. That the actual incidence of that is very small, so it's in the order of 5% or less. However, if it made the difference in terms of a curative intent therapy, that would be a big, significant issue. So for most cases, we don't worry as much about biopsying a patient who has an unresectable or an uncurable HCC, but would think twice about doing it for a patient who could potentially be curable. I'm not going to focus on this too much, but just to say that we do stage HCC with the typical TNM staging, as we do most solid tumor cancers. However, it's a little bit limited in that it doesn't take into account the concomitant liver disease, the concomitant cirrhosis that we're dealing with as well. And so this criteria is used more frequently kind of clinically, not only because of it takes into account that underlying liver disease piece, but also it's helpful in that it kind of gives providers a framework for treatment. So it's kind of a both staging and treatment planning schema. And this is called the BCLC criteria, Barcelona liver clinic criteria. And I thought what we would do is kind of use this as we move into the next phase of our discussion to talk about the treatment for HCC. I'm going to spend most of our time really focused on the systemic therapy because that's what I do. But I also just want to introduce you guys to kind of the basics of how we treat local HCC and potentially curative intent options for patients. So we'll start by walking through the scenario where we have very early stage or early stage HCC. And just to point out, because the risk of liver cancer, HCC is so common in those patients with cirrhosis, they actually get a routine surveillance with ultrasound to try to find those tumors at these early stages. That is not the case with all patients. It's limited to those patients with cirrhosis, but it can be helpful to diagnose people earlier on and give them more possibility for a curative intent therapy, mostly because liver cancers typically don't cause a lot of symptoms. There's not pain related to the liver tumors in most cases. So let's just follow a little bit through this paradigm and thinking about the very early stage and early stage cancers. So very early stage is one tumor that's less than 2 centimeters in a patient who has preserved liver function and an excellent performance status. Early stage would be either more small tumors or a larger tumor up to 3 centimeters, still with preserved liver function. And you can see kind of the key thing as we're thinking about these patients is because they have this liver disease, we really have to consider their candidacy for surgery or a liver transplant. And so if we kind of walk through, the way we decide which of these makes the most sense is first to determine if they have a reason they couldn't be a surgical candidate. And for this portion, we'll talk about that patient who's going down the yes paradigm. The next question is if they have severe underlying liver disease. And this question of portal pressure and bilirubin distinguishes a person from having a significant underlying cirrhosis versus not severe underlying cirrhosis that would preclude surgery. So if we're in that camp and we're in these people who have pretty maintained hepatic function, then the gold standard and our hope is that we can get them to a liver resection. And that's basically just surgical resection of the mass that we can see. As stated, that's kind of a lower proportion of the population that we see in clinic. And most of these patients have more severe underlying cirrhosis by the time they've developed HCC. But for that small patient population who is amenable to surgery, that is our treatment of choice. However, in spite of this, the recurrence rate is still high. So greater than 70%, especially in people where the tumor has invaded some of the blood vessels in the liver or is involved in multiple sites. So we have that kind of limit of up to 3 where we might consider resecting a tumor. If we have 3 or more tumors, the risk that the liver cancer is going to come back is much greater. And it usually occurs pretty quickly within 3 years of the resection. In spite of knowing all this, that the risk of recurrence is very high, the studies thus far of adjuvant treatments trying to prevent the recurrence with medical therapy have not been successful. So basically, we are currently, as of present time, don't have any evidence to give medicines to try to prevent this recurrence. I will say we just completed a study enrolling that's a industry-sponsored trial of using immunotherapy as an adjuvant option for these patients. So hopefully that's something to come. But as of present, we don't have any recommendations for adjuvant therapy. So let's now talk about the next person over on this pathway, where instead of the normal portal pressure and bilirubin, those are increased, indicating more significant underlying liver disease. So those patients, it would not be safe to do a surgery because the liver would not regenerate and they have a higher risk of complications related to their clotting issues and bleeding issues, et cetera. And if that patient otherwise, though, doesn't have multiple comorbidities and is deemed after a very extensive review as a candidate for a liver transplantation, that is the second option in treatment of choice. For liver transplant, there are even more significant criteria, as you might imagine, because of the very minimal options and availability of livers, the long list of patients who are waiting for a transplant for a variety of reasons. So for patients with liver cancer, they want to really select the person that's least likely to have recurrence of their cancer after a transplant. And that is most commonly, the criteria most commonly used is called the Milan criteria. And that is a solid tumor less than 5 centimeters or up to 3 lesions less than 3 centimeters. Also, they require that the patient not have any invasion of the big blood vessels of the liver, and again, have no other comorbidities or reasons that transplant would not be a good idea. And patients with liver cancer do get priority on the transplant list, meaning that because of their additional risk with HCC, the risk of their prognosis on top of cirrhosis when HCC is added, that does escalate them up on the list to be kind of higher or next in line to get a liver. And then finally, so for those patients, either who are not a transplant candidate because of associated comorbidities or not a resection candidate because of comorbidities, then ablation can be considered. And ablation is a liver-directed therapy that is done percutaneously. Basically, they insert a catheter through the blood vessels of the groin and then enter the liver and use the hepatic blood vessels using contrast under imaging guidance to show them where the tumor is located. And then with that guidance, once they've identified the tumor, they guide a device to ablate the tumor in one of a few ways. It can be chemical-based with alcohol. It could be temperature-based, which is the most common for most of our patients, with radiofrequency or microwave. And really the goal of this is to induce tumor necrosis. So you can kind of see in the picture here, they've identified the tumor in the first image. The second image is how they administer either the radiofrequency microwave ablation. And then this is the outcome, is that it leaves a necrotic area where the tumor has been completely eradicated. I will say this is, again, really limited to those patients where a surgical option is not possible for whatever reason, because we don't consider it as a definitive curative intent. There's a higher risk of recurrence with this than with a surgical procedure, but is a good option for someone where surgery couldn't be considered. Okay, so that's kind of our early stage group. We're considering resecting, transplanting, or ablating. Now let's move into the kind of more commonly seen patients, which are the intermediate to advanced stage. The intermediate stage of patients means they have what we call multinodular disease, so more than 3 tumors in the liver, which we commonly see with HCC, can actually have multiple sites of disease within the liver without metastatic spread. But these patients still have pretty well-preserved liver function. So those patients, we talk about doing alternative liver-directed therapies like chemoembolization. So these are the same idea. They're performed through transarterial procedures. And they really, the key aspect of these patients is that they must have disease limited to the liver, right? We don't want to give someone a liver-directed therapy focused on liver-only disease to someone who also has lung metastases. So this is the key criteria, as well as the fact that these procedures are administered through the blood vessels. So they have to have normal flow of those blood vessels to the liver. So if there's a blood clot or other abnormal circulation for a variety of procedures they often do for cirrhotic patients, these procedures would not be safe. In the bottom corner here, you can see a picture of the fluoro. So this is like the in-procedure image that they're looking at as they're performing the procedure. And what they're doing is highlighting the blood vessels that supply the tumor in the liver. You can see they've pointed out on the top is the carcinoma. And basically what they do is they administer either directly into the tumor a treatment, for example, chemotherapy that could be infused directly in the tumor. And then obstruct the blood vessel. So they are cutting off the blood supply, or they can just cut off the blood supply without administering a treatment. Kind of the standard 10 or so years ago was to do that chemotherapy infusion and then block the blood supply off. Now they've become more sophisticated with technology such that they're able to provide beads labeled with chemotherapy or even radiation to a tumor to provide kind of a less toxicity and more directed therapy to that site. These are microscopic particles. They're not something you can see with the naked eye, but are less likely to cause systemic infusion and side effects from the therapy. Okay, so now we'll spend a little bit more time focused on the treatment for advanced stage disease. And these are those patients who are basically not candidates for any of the prior. Either they have spread of their cancer outside the liver or invading those big blood vessels that make the other treatments not possible or not advised, but typically still have preserved liver function. Usually these patients, as we're meeting them in the clinic, are not a PS of 0 anymore. Their ECOG is declining by this point of their disease course. And I will say that about 5 years ago, this talk was pretty short. There were not that many options for treatment of HCC, but you can see by this picture that as of the last year, and even there's one update I'll share with you in addition to this list from a year ago, but now we have multiple treatment options and positive studies that have led to FDA approvals for therapies for liver cancer for HCC. So I think I want to really focus on a few trials that have been practice changing and really changed the field of HCC. And that's the first line studies. And then I'll kind of briefly just review the second and beyond line options as well. But just to give a little perspective, so this was the original trial in hepatocellular carcinoma that looked at sorafenib versus placebo. So as of 2008, when this was published, there were 0 medical therapies approved for HCC. There were over 100 clinical trials looking at different therapies, and all of them were negative, mostly because patients with HCC and cirrhosis have a really hard time tolerating chemo. They have liver disease, and we've process most of our chemo through the liver. So that factor made it much more difficult for patients to tolerate. So you really had to improve survival significantly without also causing harm to the patient and their underlying liver disease. So sorafenib was the first to show a benefit. This was a phase 3 randomized trial, 600 patients. And a key thing I want to point out about every study, it was first in the SHARP trial as presented here, but every study after uses child class to identify if a patient's underlying cirrhosis and underlying liver disease is not so severe that it would be a factor that would be too dangerous for them to participate in a clinical trial. So the child class is a score basically that we calculate using 5 factors. Some of them are labs, so INR, albumin, and bilirubin level, but 2 of them are pretty subjective. So they're symptoms that can be related to cirrhosis, which are hepatic encephalopathy, so confusion related to lack of processing toxins from liver disease, and ascites, so fluid collection in the abdomen. Those are measured by your choice, the provider's choice of, is this mild, moderate, severe? And each of the parameters is scored. But you can see how that's a little bit subjective, which makes it somewhat difficult when we're thinking about enrolling patients in clinical trials, or even more after that clinical trial enrollment, knowing for those patients who are kind of just a bit outside of that criteria, if it would still be safe and reasonable to provide these therapies. That said, all the studies have done this since the first one did. They've all used the same scoring system to identify if a patient is suitable for study participation. So you can see here, this is the outcome, the survival curves. Sorafenib at the top line was median survival of 10.7 months versus placebo 7.9. Not too earth-shattering, as you might take note, but was positive in terms of the statistics designed and the first positive study ever for medical therapy for HCC. So this was published in 2008. Oh, and just a comment on the side effects. So as you guys probably know, in terms of sorafenib as a tyrosine kinase inhibitor, targets multiple different kinases that we know are related to cancer. We think most likely the reason it's effective in HCC is because it does a lot of targeting of VEGF and the blood vessel pathway, given that HCC is such a vascular tumor. But as you also probably know, the toxicity profile of TKIs, even though they are oral pills, still a bit of a difficulty for patients. So kind of the key things that I've pointed out here that we see frequently in the clinic, definitely weight loss, anorexia, diarrhea, hand-foot syndrome as the common. Alopecia and voice changes were really noted as significantly increased in the treatment group. I don't notice that a lot in our patients, but definitely as an ongoing therapy, an oral pill that you're taking consistently, rather than cycles of chemo where we make you feel bad temporarily and then you feel better, having those kind of chronic ongoing side effects can be difficult over time for patients. So after 2008, we went 10 years of negative studies before a second positive study in HCC. And this is, you can see published in The Lancet in 2018, was a second tyrosine kinase inhibitor, lenvatinib. Lenvatinib is approved for other indications as well, slightly different profile of kinase targeting compared to sorafenib with a bit more VEGF targeting. And this study was interesting because there had been so many negative trials of other TKIs and other therapies, targeted therapies, trying to kind of compete with sorafenib in the first line setting, or really any line to bring more benefit to HCC patients. And they had all been so miserably negative that studies began to be designed in terms of non-inferiority studies. So they weren't even trying to be better than sorafenib. They were just trying to be equivalent. And so that's how this study was designed. It was a randomized phase 3 study. And because of the non-inferiority design, needed a lot more patients. So nearly 1,000 patients participated, and they were randomized to lenvatinib or sorafenib. Again, they limited it just to that best underlying liver disease, underlying liver function with the child class A population. And they also had some additional limitations, again, because there's a little more of the blood vessel targeting with this drug. So they limited it to patients who had less than 50% of their liver involved by disease. They could not have invasion of the big blood vessels like the main portal vein or the main bile duct. So that kind of limited the population due to theoretical risk and concern for toxicity. But you can see by these survival curves, they look very similar. So they met their goal. The lenvatinib was considered non-inferior to sorafenib. And that is determined by this non-inferiority margin, which was pre-specified. So basically they said, we don't want the hazard ratio to be more than 1.08. That's how we decide that it's non-inferior. And so it met that goal. And so at that point in time, lenvatinib was considered another first-line option. Not one was considered better than the other, but you could use either. I will say, just of note, I didn't show this graph just out of time concerns, but for a period of time when this was our only two options, basically more providers would lean towards lenvatinib because the response rate was better. It was quite significant. I'll show it actually here in a summary slide in a few slides. So I would say for a period of time, more of us started using lenvatinib as a first-line option. You can see the median overall survival wasn't really much different, 13.6 versus 12.3 months. But the response, the shrinkage of liver tumors was kind of strangely greater with lenvatinib versus sorafenib. Just a note on side effects, when you're thinking about non-inferiority, if there's really no other parameters to guide you one way or another, maybe toxicity would help you determine if one is better. I wouldn't really say that's the case. Pretty much across the board, the toxicity profile of these two is similar. I'm highlighting here a few that were different. So there was more hand-foot syndrome in the sorafenib group, but in fact, hypertension and proteinuria were more significant with lenvatinib, which kind of goes in line with the higher targeting of the VEGF pathways. So then in 2020, kind of the biggest breakthrough in HCC came from the IMbrave 150 study. So this was just 2 years ago now, and was kind of the clinical trial that showed the most benefit of any therapy in HCC. And so this is the combination of atezolizumab and bevacizumab, atezo, the PD-L1 inhibitor, bevacizumab, IV VEGF inhibitor. And it showed, compared to sorafenib, that there was a significant improvement in survival. So this was a phase 3 randomized trial, open label, 500 patients, and first line, again, no prior therapies. They were randomized 2-to-1 to atezo-bev versus sorafenib. And again, limited to just those patients, child class A with the best hepatic function. They did exclude, of course, patients with autoimmune disease who had had a prior liver transplant, because in those patients, we give chronic immune suppression. So their body doesn't reject the liver. So we don't want to try to activate the immune system more. There's just a too high of a risk of transplant rejection in that case. There's also, they did exclude patients who had a co-infection of hepatitis B and C and also high-risk varices. So another complication of cirrhosis is people can get dilation of the blood vessels of the esophagus, which has a high risk of causing a life-threatening bleed. So they wanted to make sure that given bevacizumab at a much higher dose than we do, at least in the GI cancer world, kind of equivalent to some given in the gynecologic cancers. But the high dose was worrisome and wanted to make sure they weren't putting patients in harm's way by including those patients. So here are the overall survival curves, and these were updated in 2021 at our GI Cancer Symposium. And you can see the overall survival median for atezo-bev in blue is 19.2 months versus 13.4 with sorafenib for a hazard ratio of 0.66. So the best overall survival that we had seen with systemic therapy to date. In terms of toxicity here, you can see the atezo-bev in the first column divided by grade and sorafenib in the second column for comparison. And kind of as you would expect, the things that we saw more significantly with atezo-bev were related to either the protein and blood pressure problems that we see with bev a little bit more than the TKIs, and the infusion reactions were more common in this group as well. Otherwise, diarrhea, decreased appetite, asthenia, that kind of just chronic feeling were more common and or more severe in the sorafenib group, along with the hand-foot syndrome. Kind of the big concern always with using immune checkpoint inhibitors and immunotherapies, cancer immunotherapies in liver cancer, was this idea that patients with cirrhosis often have chronic inflammation of the liver. So having a chronic viral infection or having alcoholism, which leads to this chronic inflammation that produces cirrhosis. There was worry that doing further activating the immune system might actually put them at very high risk of liver failure through an immune-related hepatitis kind of picture. And so that was kind of borne out in multiple trials. We didn't see that more in the HCC population than in any other cancer type with these drugs. So this kind of gave, in a large population of patients, gave us more confidence that it's safe to give these drugs. So as I mentioned, there's even been a new update since the publication last year of the summary of new drugs. And this was just presented at our GI ASCO meeting a couple months back. So the study called Himalaya is looking at a CTLA-4 inhibitor like IPI, like ipilimumab, combined with durvalumab, which is a PD-L1 inhibitor, and combining those two. So a non-blood vessel targeting regimen, all immunotherapy, and wanted to see how that fared in the first line setting compared to sorafenib. And that was their primary objective. Interestingly, they also had a secondary objective of looking at just the durvalumab, the PD-L1 inhibitor alone, and comparing that to sorafenib in a non-inferiority portion of the study. So patients were randomized to one of those three arms, so tremelimumab and durvalumab. Interestingly, in this study, patients only received a single dose. So they received one single dose of the Tremi, the CTLA-4 inhibitor, and then went on durvalumab chronically, versus the durvalumab alone arm just received that as a single agent, but kind of different than most of our like Ipi-Nivo regimens where you can continue for more than one dose. As all of our other HCC studies, limited again to child class A, and they did exclude people who had the involvement of the big veins of the liver. As you can see from the curves on the left, the primary objective image of overall survival, that there is a separation of the curves with a median overall survival of 16.4 versus 13.8 months. And in the overall survival for durvalumab alone versus sorafenib, interestingly, was kind of similar. So 16.6 median versus 13.8 months. If you just kind of look at these side to side, though, you do see a little bit more separation of the curve, that tail of the curve we like to talk about, for a subpopulation where this combo of the CTLA-4 and PD-L1 really helped patients. Those patients seem to fare really well, but it's a subset of the population that benefits in that way. I just want to take a quick moment to talk about side effects here, because I think it's important to note that we kind of overall think of, wow, immunotherapy is so much better tolerated than a TKI, for example. But you can see that in this study, there were actually treatment-related side effects leading to death in 2.3% of patients, 9 patients total. And that was more than in the sorafenib arm. So something to keep in mind, especially in this liver population. But with a very intensive immunotherapy regimen, they still didn't see a significant increase in liver-related events versus in sorafenib. So this is just to kind of summarize all the data that we have now in the first line setting, and just to kind of show that atezo-bev combination is our current standard of care. That's the first treatment option we're going to go to, and that survival is the greatest across trials, but followed closely by the combination of the non-VEGF containing regimen with tremelimumab and durvalumab. And then still for some patients, we could consider lenvatinib or sorafenib, and perhaps for maybe a borderline patient could even consider the durvalumab alone. And I think I wanted to point out, just as kind of mentioned before, in the overall response column on the very right, you see that most of the immunotherapy containing regimens, our response rate are somewhere in the 15 to 30 kind of percent range. Sorafenib in the original trial was abysmal. It was only 2% of patients had shrinkage of their tumor. And that's why it was so surprising in the lenvatinib study that another TKI could do something similar to what we see now in the immunotherapy trials. So interesting to note the differences there. So in terms of therapies beyond the first line, so now that we have more treatment options in this first setting, more patients are going on to receive additional therapies. And I'm not going to go through each of these, but just to point out that have been approved, including other tyrosine kinase inhibitors like regorafenib and like cabozantinib. Also other VEGF inhibitors, so similar to bevacizumab, ramucirumab. And then there are also other immunotherapy combinations that are approved, including ipi-nivo in the second line setting and pembrolizumab alone. I highlighted the last row here in red because nivolumab was initially approved by the FDA as an accelerated approval when the original phase 2 study came out, but subsequently there wasn't sufficient data to kind of further support that. So just last year they revoked that approval, and nivolumab is no longer FDA approved indication. So kind of uncommon for the FDA to do that, but in the last number of years with immunotherapy, they've been doing this kind of expedited approval more frequently. So not too surprising to see some of those that don't pan out with more investigation. So I think the big thing, take-home points for liver cancer for HCC is that we really are seeing this most in patients who have cirrhosis underlying, that resection and transplant can be a cure for these patients, and that liver-directed therapies can be considered for those who aren't candidates for those. And now in the last 10 or so years, we really have many new options for systemic therapy, including immunotherapy, that has led to patients coming more often to our clinic to kind of be considered for systemic therapies than ever before. All right, so let's see how we're doing on time. Not too bad. Okay, great. So now for the rest of the time, we'll talk about biliary tract cancers. Before we go on, any questions in the chat, or anyone want to stop to ask anything now before we move into the next topic? I don't see anything in the chat, so I'll keep going. All right. So I think biliary tract cancers are a little bit difficult, are a little harder to wrap our minds around. They're kind of hard to visualize because they are cancers of the bile ducts, and they also have a lot of different names and terms around them. So bile duct cancer refers to basically any cancer within the biliary tree. That can include ampullary cancer, it can include gallbladder cancer, and it can include cancer specifically within the bile ducts themselves, which, as you can see in this picture, range from the where the ampulla vator connects the small bowel, the duodenum, to the biliary tree, all the way up to where it connects to the liver. So cholangiocarcinoma specifically refers to cancers within the bile duct, and we separate out gallbladder and ampullary cancers as separate entities. But even within cholangiocarcinoma, we use different terminology still. So we talk about the cancers within the bile ducts of the liver versus the cancers occurring within the bile ducts outside of the liver. So those we consider extrahepatic bile duct versus intrahepatic bile duct. And then to make it even more complicated, a very particular area where the common bile duct, the common hepatic duct branches into its main two divisions to supply the two sides of the liver, we call this a hilar cholangiocarcinoma. So basically, we have gallbladder cancer, we have ampullary cancer, we have intrahepatic bile ducts in the liver, we have hilar cholangiocarcinoma at this very focal point, right where the bile ducts branch into the liver, and we have extrahepatic bile duct cancers, which are everything between the ampulla and below the hila. All of those together are the biliary tract cancers. And clinical trials are a little tricky because they may divide them up by all bile duct cancers. They might say only cholangiocarcinoma. They might say only intrahepatic cholangiocarcinoma, only extrahepatic. So it's a rare cancer to start with, and then we kind of start parsing out these subsets of the disease, which kind of makes it confusing to kind of wrap your mind around. The reason that that's important, though, and the reason that we do that is that we know within the last number of years, with the advent of widespread sequencing of tumors, that intrahepatic cholangiocarcinomas, extrahepatic cholangiocarcinomas, and gallbladder cancer in particular are very different in terms of a molecular pattern. And you can see intrahepatic cholangiocarcinomas on the right. That's the long list of various alterations that we may see in these tumors, versus much less common to see that in extrahepatic cholangiocarcinoma. And so that'll come to play as we talk about some of the treatment options available for these diseases. The risk factors for bile duct cancers. So pretty uncommon for us to see a liver fluke infection as the risk factor for bile duct cancer, but worldwide, this is one of the more common causes. In the United States, what we see more is kind of uncertain etiologies, but potentially bile duct cysts or chronic stone disease might increase risk. And then kind of a less strong association, definitely, than with hepatocellular carcinoma, but a possible association with hepatitis C. And then there's a rare hereditary syndrome and autoimmune disease, primary sclerosing cholangitis, where they develop chronic inflammation in the bile ducts that produces cirrhosis. And this can also lead to biliary tract cancers. So as you can imagine, making the diagnosis of bile duct cancer is not a one size fits all. It depends on where we're talking about. Are we talking about an intrahepatic cholangio? Are we talking about extrahepatic or hilar? I think the big things just to take note of, though, are that intrahepatic cholangiocarcinoma is difficult to distinguish from a metastatic lesion. So basically, if you have a patient who comes into the clinic, they have full imaging of their body, all we see are masses in the liver, we can't just assume that that's cholangiocarcinoma. It's such a rare diagnosis that we have to exclude that this is an occult primary, meaning a primary cancer that we're not picking up on a CT scan. And for us in the GI world, that basically means we have to do a further evaluation by scoping above and below, looking for gastric, esophageal cancer, colon cancer, rectal cancer, looking throughout the GI tract, as these are areas that tumors could be potentially missed on a CT scan. So that's kind of the key consideration for intrahepatic cholangiocarcinoma. In terms of extrahepatic or hilar lesions, typically these are identified on imaging. However, they may be small, right? Like if this is a tumor within the bile ducts that's not far advanced, maybe all it causes is an elevation of the liver function tests. And so sometimes these tumors may be diagnosed by procedures like an endoscopic retrograde cholangiogram, which is an ERCP, or an endoscopic ultrasound. So these are procedures where they actually go through the mouth with a camera, tinier camera than they would for just looking for, stomach or esophagus problems. A tiny camera that actually enters through that small bowel and into the ampulla, into the biliary tree that we saw in that last picture. And then from there, they can kind of do the same thing we saw in those pictures of the IR procedures, where they can inject contrast and get a look at the bile ducts and kind of create a picture of that. There's also a way to do that with MRI. It's not as good as the cholangiogram, but could be considered for some cases, and sometimes is more effective for those hilar lesions where they're right at the branch of the biliary ducts, biliary tree. So then in these procedures, when they're doing the ERCP for the hilar or extrahepatic cholangiocarcinomas, as you can imagine, they've got this little tiny camera and an even tinier brush that they're using to get cells. So this is not like where we're sending someone for a liver biopsy like we might do for an intrahepatic cholangiocarcinoma, where we just put the needle in the liver like we do for other tumor types. Here we're dealing with such microscopic and small areas that often the most we can get is some brushing of some cells. Our group here is excellent. Our GI group is excellent. And sometimes they can get a needle biopsy to get a little bit more tissue, but it can be pretty limited. So it often is hard for a localized bile duct cancer, for a localized extrahepatic cholangiocarcinoma, to make the diagnosis based on such limited findings, such limited cells. And so to kind of help with that, there is a specialized FISH test that they can do on the cytology specimen to perform on those cells that can kind of help give further support to a cancer diagnosis. And I provided a picture here in the corner of what that looks like. In the bottom image, the polysomy is what is supportive of a malignant process when they look at it in the cells. So kind of similar to what we discussed in hepatocellular carcinoma, thinking about a biopsy for those patients with the intrahepatic cholangiocarcinoma, we kind of run into the same risk of potentially seeding this biopsy tract. And in fact, the surgeons and transplant doctors would say that they worry more about seeding a tract of cholangiocarcinoma even than HCC. Typically we would do it, especially in an advanced setting, we would definitely want to have tissue diagnosis. But if it's somebody who may be a surgical candidate and go straight to the operating room, many times we would not biopsy that. If it had, significant concerning findings, they may go straight to the operating room to prevent this risk. Okay, so let's spend the last about 15 minutes that we have talking about the treatment of biliary tract cancers. And again, we'll spend a brief amount of time talking about the curative intent, but really focus more on systemic therapies. So surgical resection, of course, is the gold standard and the only cure for bile duct cancers. And this, I'm not going to go through each of the procedures because that varies according to the location. And I will say the one thing that we run into in our multidisciplinary conferences is that oftentimes imaging underestimates how extensive the disease is, because again, we're dealing with such small areas, such a small part of the anatomy, that oftentimes when the surgeon gets into the operating room, they find there's actually more involvement of the biliary tree than they had initially expected. And you can see here, there are still not as severe as HCC, but still a pretty high risk of recurrence after resection in these diagnoses. And in this disease setting, there is a positive trial for adjuvant therapy, which is oral capecitabine, a 5-FU drug, and also a phase 2 study that shows some benefit from combining chemo and radiation. So there are some adjuvant options that we consider in patients following a curative surgery. For patients who are not surgical candidates, this is usually because of the location. And kind of the reason we separate out that hilar cholangiocarcinoma group is this is a very specific location that makes it nearly impossible to do a resection because you basically would lose the biliary supply to the entire liver if you had to cut out that hilum. You can survive with half of the biliary tree supporting half of the liver, but not with the entire hilum removed. So if there is a tumor in that region, in very select rare patient population, a liver transplant could be considered. This kind of meets the same criteria as the HCC group, but even more stringent because of the kind of increased risk of metastatic spread of bile duct cancers versus HCC. So their rules are kind of generally established rules are that the patient must have a less than 3 centimeter isolated tumor and no evidence of any suspicion of nodal disease, of course, no evidence of metastatic spread. So there's a protocol that we use, again, in rare select cases, but it's called the Mayo Protocol as it was initially performed in Mayo. And basically patients get radiation and chemo with 5-fluorouracil. Again, usually here we use oral capecitabine. And then after they've completed the 5 or 6 week course of chemo radiation, then they continue the chemo until the transplant. And, a patient can be on a transplant list for many months and years. So that's a kind of a big undertaking. However, that's kind of the criteria required to confirm that a patient isn't going to have spread of their cancer while they're waiting for a liver. We don't want to give a liver to someone that's just going to have progression of their disease when we put them on immune suppression. So in the Mayo data, the overall survival with transplant is 50 to 75%, but it's only at one center and not a kind of a widespread accepted regimen at this point in time. Okay, so we'll spend the last few minutes talking about the systemic therapy for cholangiocarcinoma. And you can see kind of similar to HCC, it's been quite a number of years that we had our first approval for an effective regimen that was shown in a randomized clinical trial in cholangiocarcinoma. These are very rare cancers, so that kind of limits the ability to do big, large clinical trials that are randomized. So this was a really impressive undertaking at the time in 2010. And this regimen is chemo. It's gemcitabine and cisplatin, nothing fancy. It was a phase 3 randomized controlled trial. They compared to gemcitabine alone, and they found that the median overall survival, as you can see in the curves here, was improved at 11.7 months for the gem-cis arm versus the gemcitabine alone. I do want to point out that they included in this trial patients who had intra or extrahepatic cholangio, gallbladder cancer, or ampullary cancers for this study. So since that time, since 2010, that was the only positive trial. So that was the only treatment we had in the first line setting. This is hot off the presses from our GI ASCO meeting just a couple months ago, the study called TOPAZ-1. And so now, in addition to HCC, we're also trying to integrate immunotherapy into the bile duct cancer setting, into cholangiocarcinoma treatment. And so the TOPAZ-1 study combined gem-cis and durvalumab compared to the standard gem-cis alone. And this was also a phase 3 double-blind randomized controlled trial, first-line setting. Here, they allowed intra and extrahepatic cholangiocarcinoma and gallbladder cancer, but excluded ampullary cancer, for whatever that's worth. There wasn't a large population of ampullary cancer in the prior trial. And they were randomized 1-to-1 to these two groups. I will say kind of the interesting thing to take note about how they designed the study is that they had patients treat with the chemo for 8 cycles, and then they stopped. And so the patients who were randomized to the durvalumab arm continued durvalumab, but the patients who were on the placebo arm just continued placebo. So it seems a little bit less impressive when you're comparing to no treatment at all, which is not typically what clinically we do. Like usually we'll leave them maybe on kind of a maintenance with gemcitabine or something, but pretty uncommon for us to just go completely off therapy after some response for cholangiocarcinoma. So it was a positive trial with a overall survival improvement, also kind of moderate, just from 11.5 months with their gem-cis arm to 12.8 months, but did meet their primary endpoint. So I think I haven't yet used this. This is new data. It's not yet in the NCCN guidelines. It's kind of a modest benefit. It appears, as kind of we see with these immunotherapy trials, that there's a subpopulation that it probably is helpful for. Would be nice to kind of figure that out a little bit better, and maybe we can really just add that additional side effect risk for patients who are most likely to benefit. But that remains to be seen. So here's what we have now for first-line treatment options: gem-cis or adding durvalumab. And in terms of second-line options, I'm not going to spend a ton of time on the chemo options just to point them out. I do want to talk about these because this is where we've integrated targeted therapies for the treatment of cholangiocarcinoma. So this is one of the 2 chemo regimens approved for the second-line setting. So FOLFOX, which we use commonly for other GI tract cancers. Not until 2021, actually, did we have any study to be positive in the second-line setting after gemcitabine and cisplatin for cholangio, again, just because it's hard to enroll these trials. So this was a randomized control trial with 162 patients. They had to have gemcitabine and cisplatin first, and after progression went on FOLFOX. Here they included the same group as that original gem-cis trial with ampullary included. And basically were randomized to active symptom controlled, no treatment or FOLFOX. And you can see that knowing they were compared to supportive care, it's not exactly life earth-shattering improvement of 6.2 versus 5.3 months, but it did meet their primary endpoint. And this is just another brief information about a second chemotherapy regimen that just was presented at ASCO last year, which is 5-FU irinotecan. We use this regimen also for pancreatic cancer. This is only a phase 2b trial and only included gallbladder and cholangiocarcinoma, but they compared from irinotecan to 5-FU alone, so they didn't compare to best supportive care, and their primary endpoint was progression-free survival, which was improved significantly when they added the irinotecan to the 5-FU. But now let's spend a little time talking about the molecular changes. So I showed you that slide of the long list of various molecular alterations that we see in the bile duct cancers. And so in order to take advantage of this, there have been a couple of studies focused on FGFR and IDH1 targeting drugs. And so pemigatinib was the first study presented that was positive, and it's an FGFR 1 through 3 targeting oral therapy. And this was a phase 2 study, but they did include 147 patients with who had been treated with at least one prior line of therapy. And you can see the majority of patients had specifically an FGFR2 fusion or rearrangements. That's the most commonly seen in cholangiocarcinoma. And really to take note that 98% of them were intrahepatic cholangiomas. So kind of as seen in that schema, we didn't really find a lot of patients with these alterations outside of that intrahepatic set. So they got this oral regimen, which is 2 weeks on, 1 week off, and their primary endpoint was overall response. And based on the most recent analysis, that is 37% response rate, which is pretty impressive. They interestingly, in kind of some follow-up data, looked at the overall survival in responders. And initially, the median overall survival was 17.5 months, but when they looked at it in the people with response, it was 30 months. So again, we're kind of now identifying that even in the group that has FGFR alterations in intrahepatic cholangio, there's a subset of people that benefit most from this therapy, which is really narrows it down. I just want to take a moment, because we're close on time, to note that there are some unique toxicities. This is an oral therapy, but phosphorus problems and eye problems are kind of the key unique things that we monitor. And just to briefly show that there's a second FGFR2 inhibitor that kind of had a similar outcome. It was also a phase 2 study and looked at FGFR2 fusions and kind of had similar with a little bit lower numbers, but very similar profile for toxicity. And then lastly, the IDH1 altered patients, which are a bit smaller of a subset within cholangiocarcinoma, again, mostly intrahepatic. There is a targeted therapy called ivosidenib for IDH1 altered cancers. And so there was a phase 3 study that was presented at ASCO GI last year that demonstrated in 187 patients randomized 2-to-1 to ivosidenib versus placebo that there was a benefit in terms of the progression-free survival. You can see by the numbers, it's not that impressive. So ivosidenib arm was 2.7 months versus 1.4 months with placebo. Again, that met their pre-specified criteria. However, you again can see this subset of patients that it really helps for a long period of time. In that left figure, the blue line is really kind of stayed stable for a proportion of patients out to 19 months versus that in the placebo arm, which is only at 6. And then the second figure, I just want to walk through briefly to show you that they also kind of parsed out those patients when comparing to the placebo arm who crossed over to the study treatment. So crossover in this study was allowed. So in the original study for survival, there was not a significant difference. So the median survival in the study treatment arm was 10.3 months versus 7.5. However, if they adjusted statistically for those patients who crossed over to the study treatment after progressing on placebo, then they were comparing a 10.3 months versus a 5.1 months median overall survival, which was a significant difference. And side effects for this drug were actually, it was pretty well tolerated, nothing too significant or surprising. So I think here, just to point out for second line and beyond, this is the space so far where we're really focusing on targeted therapies, but thus far, this is mostly in the intrahepatic population, the subset of cholangiocarcinomas that we're seeing this. But there are definitely many trials to come combining these targeted therapies and trying to move them to the first line setting. So some take-home points for the biliary tract cancers. The genetic profile of the biliary tract cancers vary according to the location within the biliary tree, and the specific location determines the surgical and curative treatment options. There are many new systemic options available just in the past 10 or so years versus none prior, at least none with randomized clinical trials to guide. And some are based on and increasingly on molecular characteristics of the tumor. So we recommend that every patient with a biliary tract cancer, even those without the kind of highest yields intrahepatic cholangiocarcinomas, should undergo molecular testing. And that is all I had today. Just finished with only a couple of minutes to spare, but would love to take any questions or comments from the group.
Dr. Davis, there's one question in the chat.
Oh, great.
Since there is typically no pain associated with these cancers, how are they diagnosed? Screening? Other symptoms? In other words, is there a way to catch it early so that treatment has a better chance? Let me see here, the rest of it. Better chance of success.
Yes, that's an excellent question. And the answer is that is only the case for hepatocellular carcinoma. So there's not a kind of screening or surveillance mechanism for cholangiocarcinomas. And even in the hepatocellular carcinoma set, it's only limited to those highest risk people who have cirrhosis. So the reason that we are not really, there's not a big move to try to do a screening and surveillance monitoring is the rarity of these cancers and the lack of a really good test to be able to diagnose it early. So for example, in colon cancer, which I treat a lot of in the GI cancer world, colonoscopy, we can not only diagnose a cancer, but we can diagnose a precancer, a polyp that can lead to cancer and eradicate it before it comes a tumor. So in this case with cholangiocarcinoma, we don't have that same capability. Now, I will say there's a very small subset of patients who are very high risk, that group of patients with primary sclerosing cholangitis, this rare kind of autoimmune-like disease of inflammation of the bile ducts. In those patients, there are often kind of evaluations with tests of CA19-9 or really close monitoring of liver tests. If they were to increase, we would do an ERCP. But because it's so difficult to make the diagnosis on its own, as of yet, with our current capabilities, there's not a strategy to find this. Something that we're in great need of, though.
Thank you. Are there any other questions for Dr. Davis? It doesn't look like there are, so we thank you very much for being here, and you may go back to treating patients.
Thanks so much for having me. Thanks to you guys.
Thank you. Bye.
Bye.